So you have a thyroid nodule. What now? Welcome to Talking with Docs. I'm Dr. Brad Mabini.
And I'm Dr. Paul Zalzal.
I'm Dr. Amy Mabini.
Dr. Mabini is an ear, nose, and throat surgeon who's going to help us with this topic. And full disclosure, you saved my life. Really did. Remember a few years ago, quite a few years ago, I had a real bad infection in my throat.
Yeah.
I was fairly reluctant to seek medical attention, which is a mistake. And then my surgical assistant with me actually put me in a headlock, which made it harder to breathe. Took me to emerge. You saw me and put me in the ICU.
This is not a joke. He actually really would not go see the doctor.
Yeah, I think I went from work to ICU in like a world record time.
Yes.
But I put you on steroids. So you have to blame me for your hip replacement in a few years.
Side effects of steroids. Luckily, I have not had any. But you did save my life, so I owe you a coffee.
Okay, so when it comes to thyroid nodules, these are very, very common. Let's start at the beginning. What is our thyroid? What does it do? Why do we have it?
So thyroid's an organ, and it produces your thyroid hormone, which helps with your metabolism and how everything functions in your body.
Okay, and it just lives in the front of our throat?
Just in the front part of the neck, but sometimes it's not as obvious here. It's usually lower down in this area.
So the bump you see there, is that the thyroid or is it just below the bump?
No, so the bump you see here, what you call the Adam's apple, that's actually your thyroid cartilage.
Okay.
But it sits below that.
All right.
Okay, so how would someone know if they have a hot thyroid nodule?
They don't always know.
Right.
So it's actually someone else that sometimes identifies it.
Right, so if you had a really big one, someone might see it or feel it.
Yes.
And then the other way, apparently, is with other investigations that are done
Yes.
for other reasons. So if you had like a neck CT scan for some other problem, someone says, hey, we noticed that you have a nodule on your thyroid.
Yeah.
Now we have to talk about this.
Yes.
And that's a little different than a goiter, right? People always say goiter.
Goiters just means that it's a big thyroid.
Big thyroid.
Yeah.
As
Okay.
opposed to a nodule, per se.
So you have a nodule, whether it's symptomatic or not, you're at your family doctor. What do we do then? How do we work through the history and the physical examination of a thyroid nodule?
So normally the family doctor, once it's identified, they'll order actually blood work. So
Yep.
looking at your thyroid hormone levels. So it's a TSH that they order, thyroid stimulating hormone. They order T3, T4, and they also look at calcium and magnesium because there's glands just behind it that are called parathyroid glands that actually control it, but they don't rely on the thyroid itself.
Okay.
It's kind of cool because you're looking at levels in the blood of a hormone that stimulates the thyroid, and then you're looking at hormones that the thyroid produces, and depending on those levels, you can actually determine if the thyroid is working properly or if it's not working properly, if it's getting a signal to do something and it's not doing it, or if it's doing something without the signal. So you can get a lot of cool information from those blood levels.
And when you're thinking about the thyroid nodules, there are certain things that increase people's risk of having an issue or a thyroid nodule that's more important. Is that fair to say, like when it comes to gender, age,
Yes.
iodine exposure, not
Yes.
iodine, sorry, radiation exposure,
exposure, yes.
or iodine deficiency? Would those be the four categories primarily?
I would say so, yes.
Okay. And what would we say about gender?
So gender, so men don't normally have thyroid nodules as often as women do, and they say for women it's because of our estrogen levels.
Okay.
So if you were to ultrasound a woman and you saw that there are nodules there, as long as they're a certain size or smaller, you just follow them.
Okay.
But in men, you do start to worry earlier regarding that. And also from an age point of view, for men, it's over the age of 45, and when there's a higher risk than below that.
Okay.
And we don't mean to offend anyone with our gender discussions, but in medicine, often it's important to know if someone is XX chromosome or XY chromosome because it predisposes you to certain diseases and determines your treatment options. So that's why we often say things like, when men this happens and women that happens. But we are sensitive to the various gender discussions that are going on right now.
Okay, so you've done the history, you've done the physical examination. Like you said, often if they're small, you actually can't feel them. What is the gold standard test for diagnosing a thyroid nodule?
So an ultrasound is the gold standard. So even though it's been identified by accident with an MRI or a CAT scan, the best imaging is an ultrasound of the neck.
And the purpose of the ultrasound is to identify not only the size, but whether it's fluid filled, what its borders are like, that kind of thing?
Yes.
Okay.
Ultrasound, so useful. So ultrasound's a nice non-destructive way of looking at tissue, right? It's just sound waves we bounce off to look at contours and shapes and things like that. And it's a safe test. There's no radiation involved with ultrasound. And you can't hear it because it's ultra.
That's right. So now you got a nodule. Now what are we gonna do? How do we find out beyond just what we have so far, whether or not the nodule is something that we need to do something else about?
So on the ultrasound, they will look at different features. So one of it is the size, of course.
Okay.
The other one is if it's solid, or if there's a mix of solid and fluid, or if it's only fluid filled. The third thing is whether there's little spots of calcium deposits either within it or around it.
Which is not necessarily a good thing. Like that it increases the risk of that lesion.
It does. The teaching was it increases your risk of for thyroid cancer about 40% if you see calcifications.
Okay, and that's basically what we're worried about here, right? If you've got nodules, we're worried that you might have cancer in your thyroid.
Right.
Is that the idea?
It is, but you can also have a nodule that what we call hot. So if it's overactive, then you could have Graves' disease, which is hyperthyroidism, but that's usually identified through blood work, though.
Okay, so not all nodules are cancerous, but that's one thing that the surgeon or the doctor or your healthcare professional is going to try and rule out and make sure this isn't a cancer.
Yeah.
Okay, so now we're suspicious that it's cancer, depending on its features and its size. What is the next test that we do to try to identify whether or not it's cancerous or not?
So if the radiologist reports a certain kind of criteria that they have, so there's a grading system. It's spelled TIRAD, and it ranges from 1 to 6. If it's 1 to 3, it's usually less suspicious features, and so they usually recommend more observation and follow-up ultrasounds. If it's 4 to 6, there's a higher risk of having thyroid cancer in it. So that's when we would order what we call a fine needle aspiration biopsy.
Okay. And what's interesting, I learned when I was studying for this, is that you guys have agreed on some nomenclature and some language that's used by the radiologist so that it's more useful for everyone, saying you have to specifically talk about these things so that we all can understand what you mean. If someone else, you didn't know your radiologist, but you could look at the report and meant the same thing to everybody. Okay, so we're on to fine needle aspiration.
Yes.
That sounds bad. You're going to put a needle in my thyroid.
FNA.
FNA.
Yes.
And so typically where is this done and how's it done? So
it can be done either by the radiology clinic, which is where I tend to send my patients to because they're just set up to do them more frequently.
Sure.
But you can have a surgeon also do that procedure for you, or some endocrinologist who is a medicine doctor that specializes in endocrine glands, and thyroid is one of them. He or she may also do the needle biopsies.
And this is just under local anesthetic?
Just under local. Sometimes it's done without local.
Ooh, FNA sounds effing painful.
I
can't say that.
When I
don't know.
was training, one of the staff men, he'd say that it's still going to be a needle in there, whether it's frozen or not. So
to be honest, I kind of say the same thing for the knee because people are like, are you going to freeze? And I'm like, well, I could maybe freeze just the top part of the skin, but the needle goes so much deeper. You can't adequately freeze the whole thing. So
no, but if you're doing, normally we're supposed to do at least 3 samples, separate samples. So I don't know, I think sometimes the freezing may help.
I would agree. Right. And the reason that you have to do 3 samples is imagine if you were putting a needle into an orange. You hid something, maybe you hid some dye inside of the orange. There's a possibility that you could take samples from 3 different locations and not get to the dye. So that's why we're hoping to get a representative sample and not miss a smaller area of cancer. Okay,
that's FNA. What about the other way to biopsy? Is there any other biopsies you do if you don't do a fine needle aspirate? Do you ever take a significant piece of the thyroid, or is that just with the thyroidectomy that it's a biopsy?
I think it depends on what you're looking for. So the gold standard really is fine needle aspiration. But if you're, say, ruling out a lymphoma and you need more chunks of tissue because we need to send it away for different analysis, then sometimes they will get a core biopsy done here.
Okay.
Yeah.
So once you've done the fine needle aspiration, those cells go off and they're looked at under a microscope, and then you're told, for sure it's not cancer, for sure it is cancer, or maybe it's cancer or indeterminate. Is that fair to say?
I don't know about for sure.
Radiologists
and pathology will not say that.
Okay. Yeah. Highly suspicious versus not cancer. Is that fair to say? Or not really?
Yes.
Okay.
I think that'd be first. It'll say benign.
Right. Okay.
Or it'll say atypia of undetermined significance.
Okay.
It may say suspicious for follicular neoplasm, but neoplasm can be cancer and can be non-cancerous, or suspicious or consistent with a certain type of thyroid cancer.
Okay.
Okay, and then based on those results, that dictates your next treatment plan, I suspect.
Well, what I recommend, yes.
Right, okay.
Okay, so then how do you go through that? So someone's got a nodule, they've had a fine needle aspiration, they have some results, now they're sitting in your office and you're looking at the report. So say you have the benign group, what do you tell that person?
So with the benign group, and if really their ultrasound shows that there's not a lot there except for more size,
Yeah.
and it does recommend more follow-up, then if the patient is comfortable with the idea of repeating the ultrasound somewhere between 6 to 12 months,
Yeah.
and if there's some growth there, they may need another needle biopsy.
Okay.
It really just depends on
It's very
their
individualized, obviously. So
anxiety,
yeah.
related to it.
Okay.
Yeah.
And then, so what if you're in that group of the atypical cells group?
So the atypia, so that usually means about a 25 to 30% chance of having cancer in that nodule.
Okay.
So I guess I should go back. The general risk that we all have without knowing any other information about a nodule is 7 to 11%.
Okay.
So 25, 30% isn't huge, but it's still an increase
Yeah, makes
in
you
your
feel
background risk.
uncomfortable. Yeah.
If you really want to know more information about it, sometimes, well, actually, usually we do repeat the needle biopsy in about at least 6 months later
Okay.
to see if we get a different result.
Okay.
But if not, then you could send a new sample to the States. And it's called an Affirma test, is one of the companies that makes it, and they do genetic testing on it.
Right.
It's not 100%, but it can tell you if there's any of the really bad genes in there,
Okay.
what the risk is for having a cancer in there.
Okay, so certain centers, not everywhere, I guess, have the ability to do certain genetic testing.
To send that, but it costs about $4,000 US.
Okay.
So it's not something that most people order.
Right.
Yeah.
Okay, and then what if you get to the point where, like, yeah, this looks like a cancer,
Yes.
and then is it straight to thyroidotomy?
It is a thyroidectomy. When I started 18 years ago, though, if it said that and it was a 1 centimeter thyroid cancer, we would automatically take the whole thing out.
Okay.
But now there's a lot more research in there, and we have a better understanding of how they progress, which ones are safe, size-wise. So if there's nothing else on the other side we have to worry about, then taking out just the one side is reasonable.
Right.
Yeah.
And the reason that we want to do less harm with surgery is, particularly for thyroid, is potentially they can not have to have thyroid replacement, right?
Exactly.
Yeah.
It's just, it all depends also on your age, I think, too, because the gland over time will weaken, right? Or not, I shouldn't say weaken, but doesn't produce as much thyroid hormone. So I think it's about, we all have a 1% chance as we get older that our thyroid will reduce its function,
Right.
and that we might need replacement.
Okay. So now you've had your thyroid out.
Yes.
What's the prognosis for someone with thyroid cancer? So speaking about all cancers, obviously some of them are very, very serious and have a high chance of even death. Thyroid cancer actually is a pretty treatable cancer.
Depending on the subtype,
Yes.
yes, definitely.
Generally speaking.
Yeah, and I know people will say, if you're going to have a cancer, this is the best type. I don't like to say that because once you say cancer, no one's comfortable with that idea.
Right.
But if it is one of the more less aggressive types, then usually just removing it and then just having follow-up, especially if you don't remove the other side,
Right.
is a reasonable course.
It's like curative, almost, basically.
For most patients, yes. And then as long as, I always tell them that usually you will die from regular things such as heart disease and stroke,
Yeah.
than your thyroid cancer. But there are certain subtypes that can be very aggressive.
Right.
Okay, and then we always talk about risks. Anytime you have a surgical procedure, there are risks. What are some of the risks associated with having your thyroid removed?
So there's two specific things from a thyroidectomy that you have to run the risk of. So one is your calcium can drop temporarily or permanently, and that's because of those little glands I was talking about earlier, parathyroid glands. They're about the shape, I always tell patients, like the shape of a caper. So
Okay.
they're pretty small, about half a centimeter, less than a centimeter, and they sit next to the thyroid, but they do not rely on its blood supply for the thyroid. So it's like if you think of oranges and the sections when you separate it, it's
Yeah.
like that. But even if you preserve them, if, say, their blood supply gets stretched a little bit, they get stunned somehow, you can have a drop in your calcium after surgery.
Okay.
So it's really important to keep an eye
So
on
that's
that.
some collateral damage to the parathyroid hormone, which is integral in the balance of calcium
Yes.
in your body.
There's one more thing though. One is your voice box.
Yeah.
So the thyroid gland, if you kind of think of it as a fat butterfly, so
That's how I think of it.
so it sits on top of your trachea, and there's a groove between your trachea and the esophagus where food goes down. And the nerve that provides the movement of your vocal cord, it actually runs up in that space, and it goes behind the cartilage called, it's actually the thyrocricoid membrane. So it sits in there. So it's very close.
So that's your recurrent laryngeal nerve.
That's your recurrent laryngeal nerve.
Right, and that thing is at risk. Even when you get intubated for any procedure, that can be damaged. There's lots of things that can happen with that nerve. So it's a little vulnerable. So you could end up with like hoarseness or lose your voice completely.
Yes. So if it's not moving, it'll actually not move in and out normally, and so that will. Sometimes the paralysis most of the time the paralysis is temporary because it's just been stretched, not actually damaged.
Right.
But it's.
Nerves
I'm really talking about if it gets cut, right?
Okay, what percent are we talking about here? If you're having a thyroidectomy, the percentage chance of having this recurrent laryngeal nerve, either temporarily or permanently damaged, is roughly?
So permanently damaged, it's less than 1%.
Okay, so very rare.
And then the temporary part, I hardly see it, fortunately.
Yeah, okay.
So it's not.
So
it's not very
rare,
often.
but devastating, complicated, especially for talking with docs.
Right.
We lose the talking part.
But you can still be hoarse even though it's not damaged because of the breathing tube sitting there.
Okay.
So it's like a mild laryngitis.
Okay.
Yeah.
Temporary.
Temporary. Yes.
Okay. There you go.
Okay, and then so after you're all done, so say you've had your thyroid out, do you have regular follow-up? Or again, it's very individualized depending on the type of cancer and how the surgery went, whether or not you'd have to have ongoing follow-up with your ENT surgeon?
So most of the time, I actually get my referrals from endocrinologists.
Okay.
So they're already being followed by them. I'm really just the technician.
Okay.
You're like us.
I know that feeling.
Yeah.
But I follow my patients until, if they don't have cancer, then I follow them at least a year just to make sure anything potentially related to the surgery that they have issues with, I've dealt with.
Yeah.
And then I always, actually my thyroid patients are the only ones that don't need a re-referral. If there's something that's there, maybe related to the thyroid before, or their endo says you need to see Mabini back, there's a lump there. and
Right,
I'll
they
see
just
them.
call you.
Yes.
So nice.
Endocrinologists, those are the docs that sort of measure hormones, are interested in all those blood levels when they determine if the thyroid is functioning.
Yes.
And the thyroid for sure is a real team, right? So it's the surgeon, the endocrinologist, maybe an oncologist, maybe a radiation oncologist as well. There's a whole
Primary care.
Yeah, they're a
Primary
family doctor.
care is
Everybody's
usually-
involved with
The
it.
primary care is usually who identifies
They're the
it.
key.
Except for orthopods. We don't get
We're
the phone
not
call.
involved with the thyroid. Okay, now you know everything you wanted to know about thyroid nodules and thyroid cancer. So if you like this video, please like it, subscribe to our channel, leave a comment if you've had experience with this pathology.
And remember, you are in charge of your own health. Dr. Mabini, thank you so much for sharing your
You're
expertise.
very welcome. Thank you
Okay,
for having me.
we'll see you next time.